Okay, thank you everyone for joining us. Our new series for the IVC community. Joining me today is Dr. Steve Elias. So these content and videos, this new podcast style, will be going out to our email list of folks that have attended IVC. So most of you know Steve Elias. He's been since the beginning. Most of you know me, so we're not going to get into any introductions. We're going to get right to this. So, do we need more saphenous vein ablation devices? That's what we're going to be discussing today here. I'm going to show a couple slides just kind of for introductory, and then maybe unshare my screen, and Steve can share his screen. So if it looks a little choppy, that's okay. But it's going to be more about the discussion and kind of where we've been and where we're going. So these are the current options for saphenous vein ablation for the treatment of varicose veins. Most of you know these by now, and it's been divided into thermal, or delivering heat to the vein wall to close the vein and stop the reflux and control the venous hypertension, or non-thermal, meaning no heat. This is a medication in combination with a mechanical disruptor of the vein lumen. This is foam, a chemical. So we don't require tumescent anesthesia, no needle sticks in the thigh. Supposedly more comfortable for the patient. Both of them have gotten pretty decent results. Glue is right here. It's got its own non-thermal, we don't need to get into all of the terminology, but this is super gluing a vein closed. And of course, traditional surgery is stripping. So that's what's currently out there. All of these have insurance reimbursement, and we can talk about that a little bit. And then Steve's been working on some new devices. I had a group of guys with me, a little company we started where we did some first in man trials. So we were involved with all these, but now I think it's Steve doing most of the work on new devices.
Well,
So when you think of a new device, it's got to fill an unmet need. It's got to fill a gap. So is it more efficacious? I mean, let's just go with radiofrequency ablation and endovenous laser. I think we've all been happy that it can close a vein.
yeah.
So a new device, is that going to improve the closure rates? Are you going to improve upon, high 90% closure? Patient comfort has been a big one, that these needle sticks in the middle of the thigh to put in tumescent anesthesia seems to be a big deal. I'm not sure that it is. And then, of course, we want to reduce inflammation in the post-op phase for smoother recovery. I'm not sure current devices are that uncomfortable. The patients seem to recover pretty well. How simple do we want to make these things? Do we want to make it to where, in the future, a doctor doesn't need to do this stuff? Can be, do it at home. You see where I'm going. And then cost effectiveness. Do we, can it just keep reducing the cost? That was, reasonable at this point. I think the devices are expensive, and currently we have insurance is covering these things, but I mean, it's a lifestyle disease. Do we really need insurance covering this stuff? I mean, insurance, in my mind, can cover catastrophic disease, and lifestyle disease. I think should be on the patient. I mean, people would argue that, and we can discuss that. We can go back and forth about that a little bit. I don't want to get into this now. This piece. So, kind of what I want to show here, Steve, is the varicose vein market is growing. I mean, the numbers I've seen, we're only treating about 3% of the patients. I mean, with all the marketing and everything involved, the majority of patients don't go on, don't get treated, and the reasons for that I'm not clear on. But one thing for us as operators, um, if we're the ones doing this stuff and they keep cutting our reimbursement, and it's gotten to where 50 to 60% cut over the last 10, 15 years since you and I started, to where now people are looking at changing site of service, no longer do it in the OBL office, in the office, and looking at ambulatory surgery centers. Um, so that's changing things for us and how we treat them. So this is just kind of an intro for us to kind of, start discussing this. I'm going to unshare the screen, and Steve, you can give me your initial thoughts
Yeah.
on what I
So
said, and if you want to pop up your slide at any time,
I
just
will, but first of
yeah,
all, let's.
yeah.
I mean, I agree with you that it is a quote lifestyle. It's a quality of life issue. The disease. It's not a leg or limb threatening problem or life threatening problem. Um, so somehow, once something is paid for by insurance, it's hard for insurance to take it away from the constituency, so to speak, of patients. Although I am seeing a few more patients who actually have, no vein coverage in their policy. They didn't know about it when they got their policy. Who thinks that, oh, I might need my veins taken care of? So, I mean, some insurers, rarely are going that route. But
We
I,
have a couple also. They do not cover any varicose vein
yeah,
procedures.
and I remember when Medicare began and stuff, and everybody, all the doctors were thrilled. More people are going to have insurance coverage and everything. I mean, one of the doctors looked around and said, "Be careful what you wish for." And it was so now we are all beholden to what Medicare decides something is worth, paying for, and then all the other private insurers follow. And I would surmise that we may all be better in the end if the playing field is leveled and none of these, no technology covers, relatively, asymptomatic venous disease or mildly symptomatic venous disease. We're not talking about end stage disease at all.
Yeah.
And we might do less patients, but in the end, perhaps we might actually make more money, doing less patients. And
Yeah.
that's
So let me jump on that, Steve. So, and maybe now we sound like this is about us and not about the patient. So,
yeah,
it's not. So, 25 years ago, you walked into my old office in
yeah,
Kendall so we started this together,
yeah,
and these things were not covered. It was radio frequency ablation and the first generation laser, the 810. And we had already gotten to office-based practice. You came down to see, there were maybe what 10 of us in the country doing this.
yeah,
You kind of came down, hey, there's a kid in Miami doing this. We had Ed Mackey, we had Ron Bush, we had, I mean, 10 of us maybe.
right,
Um, and then, so, it was a little bit of a discussion with a patient in front of you. Look, this is the traditional surgery in the hospital. We're doing this in the office now. Got this new catheter. The patients would kind of look at you a little bit. Well, I've never heard of this. Why are you the only one doing this? Is this safe? And you had to kind of convince them. But once they got the procedure done, they were happy.
yeah,
And then insurance comes along, and now the conversation turns into it's covered by insurance. Oh, where do I sign? And we were all happy. Volume went up. We're doing a
right,
bunch of procedures. We're getting paid well. We were comfortable for a while, maybe a couple, 10, 15 years. But now they're just slamming, cut, cut, cut to where, uh, we have, and I'm going to point this way, we got a Medi-Spa down this hallway of my office, and this is the vein section. The Medi-Spa now does better than the vein section. And we had to do this out of necessity.
right,
Got a lot of overhead, as you know. I've got, ultrasound machines, a C arm, ultrasound tech, the payrolls through the roof, and the margins are shrinking. And so now, I'm asking myself kind of what I asked myself 25 years ago when I left arterial surgery. Does this kind of make sense anymore? Before it was a high liability for relatively low reimbursement for what we were doing. Aortic aneurysms getting
Right.
paid, 1,000 is ridiculous. So where this sounds like the whining surgeon right now.
No, no,
Yeah. So
I wouldn't say we're whining, and we shouldn't whine. I would just want to put it into perspective for those people listening and going forward. First of all, we all need to remember that we are treating disease. You showed this, Jose, that procedures are going up. We're only treating 3% of the people that might have venous disease. We're treating a disease that only is going to get more prevalent as the population ages. So we're treating a disease, and no one's looking for a cure for vein disease. So that's one good thing. And if we like doing it, and those of us obviously are doing it, we have.
so let's park that, Steve. Cure, you use that word, and we're going to come back to new devices and cure. Okay, so keep going.
All right. So, you're at least treating a disease where there's always going to be patients. And then you're going to have to figure out how you make a living out of that if you like doing it, under whatever the current circumstances are now or going forward. What you talk about new devices, what is bizarre to me, and many people are not aware of this, that how did it ever become that you get paid more for radio frequency than laser or something else? This was a marketing, what do you call it? A marketing home run by who is that?
Brian Farley,
Brian Farley from
VNUS Medical.
NUS. He was able to convince the insurers that my device costs more, the radio frequency device, than laser, and you should pay me more or the physician more because they're using a device that's more expensive. This is not heard of in any other aspect of medicine. If a physician puts in a total hip replacement or aortic aneurysm, whatever device they use, they get paid the same whether it costs more or less. Somehow, this was really, the guy was a genius in this respect, and that's why we're doing what we're doing now. However, with the new devices, what's going to happen? What at some point, somebody's going to say, Medicare or whomever is going to say, we are giving you X number of dollars to take care of this leg. You figure out how to do it. And doctors are then going to use whatever's going to give them the greatest return on their investment, either technique or technology. And I guarantee you will see more phlebectomies only than perhaps endovenous ablation or utilizing whatever product costs them the least. Because Jose, as you were pointed out, the results are basically the same in terms of closure rates for everything.
So, Steve, you're assuming that we still have some control. We're dealing with the corporatization of American medicine right now. These device companies have, much more. The word's not power, but let's say, they're a bigger special interest group
Yeah.
than we are when it comes to influencing the payers. They're able to get in there, and they do. Exactly to your point, you should pay for this device, for this disease. This is the money we need for the device, and the doctors are over here. Forget about them for now. And it's become about the device, not the disease. So you get new physicians that have never done this before, and they ask you that question: which one, RF or laser? Like it's the device that gives you the.
No. Yeah.
You get an ultrasound, you put a pin stripper up, you do a little tiny incision, you're going to get the same result, right?
Yes.
You got to know how to interpret the anatomy, interpret the disease process, interpret all the branches. You know what I'm talking about. You've done thousands of these, and you look at the leg, and you know how to read the leg. I call it reading the leg because you've done a million of these things. It's not about the device. It's about, you and your understanding of venous disease. And you're not pretending to cure anybody, nor am I.
Right. Exactly.
So why more devices? I
Well,
mean, what is it doing? Just because more
well,
innovation and people want to get rich? I mean, I think what they do is they look at that pie chart that I showed you. This is the market. I just need this little slice for myself.
right.
I think that's what's going on here. It's not about the patient. It's not about the doctor. It's about their little slice.
Well, you're a little more. I mean, I do think. I mean, some of it is about the patient and the physicians, but clearly they need to make money, and they're calculate. If they're not going to make money, they're not going to, introduce
Right.
new devices. I do think, and I'll just show a few of the new devices. If we really think about it, the greatest in new devices that have come out have been in the NT category or something non-thermal over the last number of years. I mean, we we have basically radio frequency, which is what we've been doing for a long time. Yeah, maybe a little bit better, a little bit smaller, a little bit faster. We have laser that we've been doing for a long time, but those have remained relatively stable in terms of significant innovations. In the non-thermal space, there's been a lot of innovations and a lot of iterations and totally new devices or improvement on a theme. And if Jose, do you want me to just show you some of
Yeah,
them? All right.
please.
So
Yep.
these are all the kind of things that are available. And we spoke about all this, and I'm going to show you some of the newer ones that are available. And here's the ones we'll talk about. This is really the non-thermals and what I call the thermal non-tumescent options. And the ones in red we'll talk about here. For Mocha devices, the Claravane and Fleabogriff have been around for a while. This is available only in the outside the US. We'll talk about these two here. Glue, there's not been all that much new. In terms of foam, there's a product called Varixio. Talk a little bit about Sonavane, and there's a percutaneous ligation device called the vein closure device that we'll talk about.
So,
All
Steve, so I don't want to come off as a total crusty curmudgeon. I'm trying to be provocative here, but you said the non-thermals so far have been a good innovation.
No,
How
I
so and why so?
I didn't say it's a good innovation, Jose.
Okay,
I
well,
said it's where the work has been done more recently,
okay.
the innovation, and that the thermals really have remained relatively stable in terms of either it's RF or laser, and not much significant improvement on RF or laser wavelength, maybe. RF is a little smaller, faster, but the great majority of innovations, we can judge whether th're worth it or not, have been in the non-thermal space. Uh, in the
Okay, so let me rephrase the question. Why is the development in non-thermal?
because people feel that it's maybe a better patient experience because they don't need the tumescent anesthetic, and I'm agreeing with you. Most people are just totally fine with that. And they're trying to say we can better, more safely treat all the disease if it goes below the knee or goes down to the ankle. And that, as you know, you've heard me talk many times. That's where I do feel the
So
non-thermal.
saphenous nerve injury below the knee, that's an advantage. I think we both agree on
Right.
that.
Saphenous sural nerve injury below the knee. So tumescent sometimes is hard with advanced disease to put in with somebody has significant lipodermatosclerosis or an active ulcer if the disease goes all the way down to that
Yes,
level.
that would be at the ankle only, not in the
Correct.
thigh or the calf. Yeah.
Correct. So these are some of the newer ones, and again, in the end, they all work. The question is, okay, where do they fit in? So this is Sonavane. It's using a high intensity focused ultrasound. This is really something totally new. It's a thermal non-tumescent. And what's happening is really basically in this area, there are two ultrasound heads. One is a regular one that looks and finds the vein, the target tissue you want to destroy. And then in this whole circle out here is, think of it as a cone, an ice cream cone. And the point of the cone, you focus the high intensity ultrasound at this point and you create heat. And essentially you're sealing the vein shut, but you're sealing it shut transcutaneously. And you don't even need a needle stick to do this. And the patient just lies on a regular table. There's no prep involved. They walk in, they pull up their shorts, and you place this. You can see the target tissue. You can see it here on the screen. Okay, you want to target here. and you can,
So, Steve, this could be done by a technician, right? You don't need
yes,
a doctor to do this.
you don't need the doctor to do this, although thus far, doctors
Right.
will.
But I mean, technically, and from what I see is for a saphenous vein, maybe a perforator
Right.
only. So a patient comes in with a bunch of ropey veins all over the leg.
No,
What does this do for us?
no, this doesn't, because the vein has to be between 12, it can't be closer than 12 millimeters from the skin. So you cannot take care of a varicosity. You can take care of the underlying saphenous. It's also pretty nice for like a short stump of an anterior saphenous that you want to seal shut and then deal with the varicosities below. Perforators, I think this is ideal for perforators. Um,
It seems like an expensive machine for pretty limited use. So,
It is, of course, it's the first or second generation. It's very
yeah.
expensive at this point, and we're just finishing up the U.S. trial, so this is not like available. I just want to show you what's.
Okay, so just briefly, what does Gen 5 look like then, Steve?
So what
Say
Gen
that,
5, yeah, what Gen 5 will look like is it'll be, you know, AI will use, we used a lot to identify the vein and identify the path of the vein so that you don't have to spend time in between each segment, making sure you're on the vein level. That's the first thing. The pulses, when you treat the vein, you have to wait for the machine to cool off and then you can shoot again, will be shorter. So the procedure will be, faster. And you're going,
potentially neovascularization of the groin, have the
right,
thing read
right.
multiple sites and
Yep,
fire, ultrasound
yep,
waves at them and
right.
cook them.
Correct. And I could also see this, but more importantly, the technology will advance so quickly, like you say, the physician doesn't need to do it. Listen, an ultrasound tech looks at more ultrasounds than most of us. They know what the vein looks like. They can program the machine, and the physician can be next door seeing another patient. So that's a potential, advantage. Again, I think it's kind of neat, honestly. I just think it's fun. Um, so that's one. Two is something called ScleroSafe, which is a dual syringe system that's a catheter that's a dual lumen catheter. And what you're doing here is you place this catheter inside the vein. Through one lumen, you're sucking blood out. And then you're infusing a foam sclerosant in. So you're now injecting foam into a collapsed vein. And what this does, this really eliminates the pullback rate and infusion rate that, say, Claravane has the shortcomings of. And this is a 4 French device. It comes in a kit like this. You put an 018 wire up, and then you put your device over it, this 4 French device directly over it. And then you're going to attach your syringe. And this is me doing this actually in Germany about 5 years ago. And you just press on the syringe with the foam, and the other syringe automatically aspirates as you're pulling back. So
So,
again,
Steve, on this one, and again, just to kind of, I'm here poking you, okay?
uh,
So this is one you take away. There's no generator, right? It's a disposable kit, so
right.
there's going to be a cost advantage. That's good. I mean, can't we just make a homemade one of these ourselves in the back table and
Yeah,
get the insurance out of the loop, get the industry out of the loop, get our a couple little tubes and syringes and make our foam and suck it out and kind of do something comparable and make the whole thing less expensive, or do we need this whole industry set up here?
I, that's a good question. I don't know the answer because you'd have to just compare it to what you just said to this and see which one is better, if at all. But yeah, I understand the point. And some people may make the point, what's the big deal? Let me just put the patient Trendelenburg, put some foam in, and it's going to work just as well. Um, this just allows. It also actually causes some mechanical disruption by when you're aspirating. You're pulling the vein together and you're making these little, tears, and you're breaking down the surface tension between the blood and the foam, so you get better penetration, similar to what Claravane does. But
Yeah.
again, you've heard me say 1,000 times, I'm saying, respect the elders, embrace the new, encourage the
Yeah.
improbable, practical, without bias. So I'm just showing you what's cooking here.
Yeah, right. No.
Now, here, this is a segmental mocha. So this now is Wavella, only been done in animals thus far. What it is, it's a rotating wire, okay, at 3,500 RPM, just like Claravane. Claravane, if we remember, the problem has been you need to infuse at a certain rate and pull back at a certain rate. And if you don't do that, you don't get the closure rates. What this is here, there's a
Segmental pullback.
there's no pullback. You place it, this is 7 centimeters long. You place it where you want to do it. You start your rotation. You then infuse 1 ml. You let it mix around for 10 seconds. Pull back 7 centimeters. Do the same thing again. Infuse 10 seconds. Pull back. So now you've
Segmental
eliminated
pullback.
segmental pullback. You've eliminated the pullback rate. You've eliminated the infusion rate. And it's going to come in various sizes. So everything's similar to Claravane, except the technique now is simplified that there's almost no variables here.
Right.
1 ml in, rotate for 10 seconds. And this is what it looks like in an animal vein here. But you get the idea. You just put it up here, you rotate, get spasm, infuse 10 seconds, come down 7 centimeters, spasm, infuse, go down. That's for animals it's working in. We hope to do first in human.
So let's compare the last two. This one's got like a motorized device on it. Just looking at it, it looks a little more expensive than the sclerosafe.
Yep.
At the end of the day, it's still sclerosing a vein with a chemical and maybe add a little mechanical to it. How do you, I mean, just spitball and compare the two? Which do you have a preference, one or the other?
I
You
don't.
need to wait for closure rates or
No, Jose, it's way too early. I mean, the closure rates for the other ones, Sclerosafe, has been done in Germany and in Israel, and their closure rates are in the high 80s and stuff. Here, this has only been done in animals, so I think it's too soon to tell. This is they're both nice because you don't care about the infusion rate or the pullback rate, which again
right.
was original Mocha device was Claravane had those two issues. So then we come to the this percutaneous closure device, and there's another device by the Amcell company, which I didn't have a picture of, does the same kind of thing. This is kind of a percutaneous ligation. And this is really ideal in my mind for
Chiba.
perforators, for Chiva, a percutaneous Chiva. It's good for short stumps of anterior saphenous, something like that. And what it does, it has two absorbable clips that in between the vein, you put the vein in between and squeeze it shut. And of course, it's easy to use. It's low profile. Everybody says that. And there's two clips in here. This is an Italian company. And you can understand. You visualize the vein. You go through and through, and then you're going to extrude the one clip, pull back, pull the vein together, and then extrude the other clip. And these stay in the body for a year, but then they get absorbed.
So
So
where do you see this thing fitting?
yeah, yeah. So perforators, I think perforators is great.
Perforators are kind of tough. I mean, you
Right.
know, it needs to be a long perforator, right? Like a thigh perforator. How are you going to get that thing into a short, stumpy ankle perforator with an ulcer?
Um, I
Can you, or have you done
I
that?
I will try to do it. I get the 21 gauge needle in the perforator when I use laser. So
But you got to go through and through the sidewalls
yeah,
for
yeah,
this, don't you?
yeah.
I
Yes,
mean,
you
yeah, that seems a little tough for like an ankle perforator.
do. Right? Maybe.
Maybe ligate the saphenofemoral junction and foam
Yep.
the rest of it, or I mean,
Correct.
is that
That's one of the things they're touting it as because you occlude the junction, you don't have to worry about foam going into the deep system. As I said, a short segment of anterior saphenous vein, thigh perforator, as you said, and the Shiva, a percutaneous Shiva technique. Um, so that's that's another option. You can see it. It's I mean it's very echogenic and it could include vessels up.
yeah, see, you got to go through and
Yep.
through. Now, how you gonna do that on a little ankle? You know
Yeah.
these things that we
Yep.
see. Yeah,
It's tough.
yeah.
Yeah. but you get the idea.
Yeah,
Yeah.
it's got a little niche. Yeah,
Right. And here's what I say, just what we
yeah.
said, Chiba, stumps, ligate and foam. So these are the things that come over the last one. Okay, so Varixio it's a foam. It's a device that makes essentially foam. If you use 1% polydocanol, that is exactly like the Varithena, and it's a high quality foam. It uses the low nitrogen, et cetera, et cetera. It automatically makes, and it's per patient. So you get 15 mLs of foam. So you don't have to worry about a canister that you have to store and stuff. This pod is used on a per patient basis, and you get up to 15 mLs. And you can see the foam is, even at lower concentrations, is nice. This is STS or 1%, and you could make any of your, let me stop sharing. You can make any strength you want. So that's what we got here.
And there's also the Cabrera device, the folks that
Yeah,
invented
that you
that,
had at
they got
IVC.
something.
Yeah,
Yeah.
yeah. So
So, I mean, is it good for us to have all these options or, I mean,
I think it's good. I mean, why not? I mean, it's fun. Um, in my mind, you can tailor, what you need. And as long as most of these are not a capital equipment investment, you can take them as needed. Now, having said that, you've also heard me say many times, you just need one thermal and one non-thermal that you really feel comfortable with. And you could probably really get by for 95% of your patients. So let's not, fool ourselves into thinking
so
like,
Steve, so back to a point you made earlier. So, Medicare now bundles it. Here's the leg, take care of it. Use
right,
whatever the hell you want.
right.
Well, how are you going to approach that with all these toys,
No, so what I'm going to approach it, and everybody else is going to approach. Listen, most people wake up in the morning who are treating veins. They go to work, they want to make some money, and they want to come home. And they're going to use whatever's going to give them their greatest, profit. Because I do feel almost all these technologies in the end give you just the same similar results. You can tweak, one is a little better than the other in this situation, blah 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 blah. But in general, the patient's quality of life, Jose, I think is basically the same with any of
right?
these.
So
And
really what we're talking about here is patient satisfaction and physician satisfaction.
right,
I think where we're going now is great patient satisfaction and high physician dissatisfaction with the reimbursement.
yes,
So we're going to have to somehow, there's the gap that needs to be bridged. I don't know that it's a new device at this point. We
no,
got great devices. We got high physician dissatisfaction. That's what's going on, at least what I see. So,
yes. Some people are dissatisfied, and look, you're still having fun. I'm still having fun doing what we're doing, and
I'm a little grumpy that we're not making money doing this like we used to.
you're a little grumpy. I tried. I don't know. In my mind, it's like, I'm sorry. I still say, and this is getting off this subject. I still say, you go to work. The patients are coming to you because they
Yeah,
want to come to you. In general, they're happy. In general, they thank you after you do something for them,
yeah.
and go home, and it makes you. I don't know. I feel good about it. I mean, there's not many professions where you go to work and 98% of the people are saying, "Hey, you're wonderful. Thank you very much, and you did a good job, doc."
Yeah.
So I guess I'm taking that viewpoint. Yes, I'm making money. Do I want to make more money, Jose? Sure, but I don't know.
Yeah, I kind of see that as a justification for us. We're getting screwed and we're kind of sweeping it under the rug because we're noble people and we're here about the patients. That's why we got into this.
Right.
Now we're in the middle of this, but make no mistake. I think I mean, I look at SVS Connect, all the vascular surgeon and surgeon websites, and everybody's the same thing. We're doing these big procedures, taking on this high liability. Yes, we have a duty to our patients, but the reimbursement is out of touch with reality, and something's got to change. That's the gap. I don't know how to solve it. Certainly
Look,
not a new device.
no,
That's the gap.
hey, no,
And I agree with you. Take care of the leg. However, just make the patient satisfied. That's the ultimate goal here.
right.
I just don't know that we need third parties in the loop. I mean,
No, I would rather third parties not be in the loop, and then, they're coming to you because they heard that you know what you're doing and they're willing to pay for it. I mean, I liken it to how many people have you had, and we're totally off the subject of whether we need another saphenous ablation device,
yeah,
but how many people have you had come to the office and you tell them there's a $10 copay? And I'm sure some of them have pets, and they go to the veterinarian, and the veterinarian says, the veterinarian says, well, it's going to cost you $600, oh, okay, thank you very much. It's
but it's a real issue, Steve. It is part of this issue. It's physician satisfaction and patient satisfaction. I put them in the wrong order. Physician satisfaction second.
Yeah,
Um, but so we function off CPT codes, as you know. We submit a code, and irrespective of your experience of over 30 years, and I'm getting close to that, you get paid the same as somebody the first day out of residency. It's a code. Third parties adjudicate the code. Well, first they need to pre-authorize it and use some, ridiculous criteria. Of course, the criteria are for them to maintain their profits while we're the jokers doing whatever they give us.
right,
It's so out of balance right now, and then new devices keep marching forward, and the money is moving away from the physicians to the business community. That's what's going on now. So I don't think that we can put our head in the sand anymore and say that physician satisfaction is high because
no,
patients are thankful. I think we're beyond that at this point. The margins are so low, especially for us with private practices, that it's getting close to unsustainable. Like I said, we're subsidizing our vein practice with a medical spa. Do I want to do a medical spa? No, but it's a necessity at this point.
no. And I agree with you. I don't know the answer to the problem either, and we've spoken about this many, many times. I really don't know the answer. As long as we have third party payers, then they control the money, they make the rules, and we decide if we want to be in this game or not. And we don't want all the listeners to think like everything is doom and gloom. I mean, you need to enter, as you said, Jose, don't put your head in the sand, realize where it's going, and understand, and don't set your expectations perhaps as high as those of us who, were doing this 30 years ago. Um, and maybe then you'll be a little more satisfied. But I do not see it getting better in the near future.
I think our listeners need to hear this, which is why we're doing this, a frank discussion between two of us that have been in this game for a while. We've seen the whole evolution and we see where it is now. And, our physician colleagues need to realize that we're getting screwed. Again, the money's going to the business community and away from us. We're the ones providing the service. We're the ones that have all the knowledge and the experience. We're taking the liability, most of it, anyways,
Yep.
and we're not getting compensated fairly like other fields. So we have what's called counterparty risk. We have another party that governs our affairs, and they're the payers. And they're in between us and our patient, and it's gotten to where it's out of control at this point. So our listeners need to hear this conversation and start thinking about this, because we need to start putting together a solution as physicians that want to take care of patients and make a living.
Right. And look, and you've done it already. I mean, I think the listeners need to plan for the future, knowing that the future is going to either be stable, but more likely less a little less reimbursement going forward. So you need to make your business plans accordingly, um, and decide where you're going to go. I mean, I wouldn't go and plan on, we're going to get reimbursed twice the amount of money 10 years from now.
There's another cut coming next year. What are you talking about?
That's what I'm saying. So you need to put that into the mix when you're making your business decisions and stuff. And there reaches a point where there's just so much volume you can do to make up for the difference in reimbursement. And it's going to plateau. You can't, and you don't want to be working, you know, 10, 12 hours a day just because you have to do that to make the same money you were making when you're working 8 or 7 hours a day.
So, in wrapping this up and closing and coming back full circle to where we started, the unmet need of the new device, I think it's going to be something that's safe, efficacious, and cheap.
Cheap, yes.
So we can get the insurance people out of the loop and take care of our patients without them. I mean, these device companies have been, they're all our friends. We know all these people in the space. But I think we've just been taken advantage of for too long at this point, and we're just, we got to do something.
Yeah, no, I agree with you. And I think, as long as all the devices work about the same in terms of improving the patient's quality of life and everything else, it is going to be what's the least expensive that's going to get the job done.
Yeah.
And there will come a time where it will be that it's not going to be reimbursed, or the reimbursement's not worth it, and you're going to have to go to some type of private pay model because, I mean,
Yeah.
you know,
We're all, yeah, well, I'm transitioning to cash. I'm figuring out a way to just, start dropping carriers. You're seeing it around. We've got some friends that have dropped insurances, concierge practices.
uh,
I got a friend who dropped insurance altogether, and to make ends meet, he's doing some locums 1 week a month till the concierge practice picks up, and he can live off of that. But these are creative ideas, and I think this is going to be the new movement. Is
no,
people getting away from insurance? We're getting screwed for too long.
yeah, no, I agree. I've been talking to some people in China, a friend of mine, and what they do there is there's a concierge practice, and quote, we will take care of you, give us this amount of money,
Yeah,
we will take care of your veins for the next 5 years.
yeah,
Okay, we'll take care of it, and you get a recurrence or a new vein within 5 years, it's on us.
yeah,
And that may be a way to go as well.
yeah. I think that's a good model.
Yeah.
All right, Steve, I won't take any
Guys,
more of your time. Appreciate the frank
always fun.
discussion.